Welcome to the third annual Joel S. Levine, MD, Health Policy Lecture. What a great day at Downstate. All you smiling faces who want to learn. I love it. But today we are so excited to have, as I said, for the third time, this wonderful lecture that honors a great Downstate alumnus, great physician, personal friend and mentor to me, and that's Dr. Joel S. Levine. A little bit about Dr. Levine. I first met Dr. Levine, let's see, it was 1994. I was a second-year resident at Baylor College of Medicine in Houston, Texas, and I had just been elected to the American College of Physicians Resident Council in 1994. And I went to my first meeting in Philadelphia, and Dr. Levine was a member of the Board of Regents, which is the Board of Trustees for the American College of Physicians. If you don't know, the American College of Physicians is the organization of all internal medicine doctors in the country and also we're worldwide. And he was on the Board of Regents. And I sat next to him at my first meeting, which is kind of intimidating. I just remember this story. And, you know, as the youngest guy at the table, this big, huge, round table, I sat next to Joel, and he made me feel so comfortable in my first meeting. And he asked me where I was from, and you know, just kind of just settled me down. I never forgot my first interaction with him. And then through the years, obviously, he became chair of the Board of Regents, and I became governor of the ACP in Texas, where I was living at the time. And then I became president-elect and president of the American College of Physicians, one of the great honors of my life. And after I think it was about a year after I concluded my term as president ACP, I had the wonderful opportunity to be named president of Downstate, his alma mater. So I think one of the first emails I got when it was publicly announced that I was the new president of Downstate was from Joel. And he said, "Wayne, I'm just so happy that you're going to my alma mater. Don't screw it up." That's Joel, right? But what a wonderful man. And it was then, I guess, what year did we give him an honorary degree, Susan? I can't remember, 20, which one? 2017. Okay, it was very early in my tenure when I'd known Joel all those years, knew about his great work at the University of Colorado, where he was senior associate dean there. He's an internist and gastroenterologist. And then he went over to Denver Health, which is one of the best public general hospital systems in the country, where he spent another decade. But I submitted his name to the SUNY Board of Trustees for an honorary degree. The SUNY Board approved it. And then I had to reach him. And I called Denver Health, and I left 3 messages, and I got no response. And then I called the ACP office. I said, "Can you find Dr. Levine for me? I need to talk to him." So they tried. And I finally got him one day at his office at Denver Health. And I said, "Joel, this is Wayne." He said, "Oh, Wayne, I hadn't talked to you in a while. How's it going?" And I said, "It's my honor, Joel, to make this call to share with you the Board of Trustees of the State University of New York have approved my recommendation for you to receive an honorary degree." At first, there was silence. And then he broke out in a giggle. He just was laughing uproariously. Dan, your dad was just cracked up over the fact that I was calling him. And after I said, "Joel, I'm glad you kind of like this." He said, "Wayne," he said, "that's nervous laughter, laughter of appreciation." And needless to say, one of the highlights of my work here is that I could honor such a great man. Unfortunately, I think it was 3 months after graduation, sometime in August or September, he called me. No, he sent me an email and said, "Wayne, I need to talk to you about something urgently." So I called him, and that's when he shared with me that, unfortunately, he had been diagnosed with a somewhat terminal illness. And I was stunned. I said, "Joel, you were just here." And, you know, matter of fact, there's a wonderful picture I'll show you at commencement. When I awarded him the honorary degree. So he was just here. And, you know, and even as a physician, it knocked me on my heels, you know, to remind us how precious life is, that we take moments in life like these types of things somewhat for granted. But he was in great spirits nonetheless. He said, "Look, I've had a great life. My kids are doing well financially. Frida and I, have 2 lovely homes. He said, I've had a great life. I have no regrets. And he said, I will keep going as long as I can, even with this terminal illness. And he did. And at the end of that conversation, he said, look, I would like to leave Downstate some money, a little bit of money, as he stated it, to start a health policy lecture, and I'll defer to you how it's organized. And I said, Joel, that would be a wonderful honor. So that's how this all came about, that phone call. And he and Frida, his wife, his widow, pledged along with his children to support this lecture. So this is how it all came about, to honor a great, great man who understood that health policy, it's not just about the doctor or the nurse in the room, but how do we design programs and policies to improve the health of everybody? Whether you live on the richest side of town or the poorest side of town. Joel understood that intrinsically. The other part of his background, which you couldn't read in that bio, is that he had the wonderful honor to spend 1 year as a Robert Wood Johnson Health Policy Fellow on Capitol Hill, where this is a program where then, I think the Robert Wood Johnson still does it, but they hand select certain number of physicians, maybe 6 a year, to leave their clinical work and go work side to side with a member of Congress or the United States Senate. And he went to work for Senator Baucus, as I recall. Senator Max Baucus was in charge of getting the Obamacare bill through the Senate. And Joel said, even way back then, we started planting the seeds of the Affordable Care Act with Senator Baucus. And he, again, cited this as one of the formative experiences of his professional career that I hope some of you will continue, that we have to get into the arena of government and politics in order to move health institutions and improve health care. So that was another great formative experience that, again, Joel is consistent with why we do this lecture. So the other thing he told me in multiple conversations, he said, Wayne, I have this niece of mine who's a physician, and she's the secretary of the Department of Health in the great state of North Carolina. And I said, wow, I didn't know that. And little did I know that tremendous physician, Dr. Mandy Cohen, would, within a few short years, be appointed by the President of the United States, Joseph Biden, to lead the Centers for Disease Control and Prevention, one of the most important, critical health policy jobs in the nation. And we are honored, again, to have Joel's niece, the CDC director, with us. So without further ado, Dr. Mandy Cohen.
Good morning. Thank you, Dr. Riley, for that kind introduction and really going through my uncle's career and his impact that he had personally here, and just know how important Downstate has been to him, but really to our family. I think you know my mom trained as a nurse practitioner, and she's here, Susan, Downstate was the place where you took two kids and gave them a career, but a way to impact so many other communities and their health. Joel, when he was thinking about this lectureship, he definitely wanted to be focused on the system and the policy, but he was very particular. He said, I want folks that give the talk at these lectures to be the people who are in the arena doing the work. Not thinking about policies, not sitting, no offense, and just in academia, we love you, but like the doers. Like he was really wanting to make sure you all, as you are thinking about your careers and building impact over the course of your career, to get to hear from folks who are in the arena doing the hard work every day. And so he's really specific about it not being just a policy lecture, but really one more about implementation and practice. And so I love that, right? Joel was the doer, and we're a family of doers, and that stems from my mom, who is here, Susan. My dad, Marshall, is here. My brother, Adam, also a doer, and then Joel's son, Dan, who was CEO and ran his own company, so certainly a doer. We're a family of doers, and that is why we are grateful that Joel was such an inspiration to all of us. As we were thinking about creating careers. Obviously, my career looks a lot like Joel's path that he took, but each of us in our family really came to our careers to be of service. And so I think that's a lot of what the lectureship embodies. So when I was charged with thinking who should come to give this lectureship, it was a very easy thought for me about inviting Rebecca to join us today to give the talk. Last year, another colleague of mine, Toyin Adaje, who grew up in this neighborhood and was the first non-family member to give a lectureship, and I couldn't have thought about it. The next best person after that came to mind was Rebecca, because I've known Rebecca now since 2017, but she has been thinking about how to change the system of health delivery in our country. It's just in her bones. And she is not someone who just thinks, she is a doer. And so she embodies what Joel was after with this lectureship. Now, she has a GAD from Harvard. She's a MacArthur Genius Award. She created Health Leads, which is an organization that is meant to think about how do we really think holistically about someone's health, but get tactical about it. How can I help you today to get a thing you need to make your life better today? And that was the ethos of that organization. And now she's taken all of that and put it into an organization called the Health Initiative to really think about what are the ways in which we need to chart a different path for our country in order to have healthier families, healthier communities, healthier states, and ultimately a healthy country and world. But it takes a different vision. And she's not just thinking about that vision, but she's making it come into reality. And so she and I met each other in 2017, just as I was taking on the leadership role in North Carolina. So I was Secretary of Health and Human Services. And the important part there is I wasn't just Secretary of Health. I had the opportunity to be Secretary of Health and Human Services, which was the opportunity to think beyond, well, what are just the healthcare levers or the healthcare dollars that we can put behind a problem? How do we think about joining all levers of government together in service of health? So how do we think about early childhood education and SNAP, which is a nutritional program, as well as Medicaid, as well as mental health dollars, and how do you bring that all together in service of families and communities? And I was just starting to wrap my mind around that, and then I met Rebecca, and she helped me lay out a roadmap to make that possible. And now North Carolina, and I hope she'll mention some of our work together, I think is a real beacon of what is possible when you think differently about what folks deserve in terms of health in this country, and that leaders need to do something. If we want something different from our system, we need to do something different in order to make that possible. And Rebecca has always been an amazing partner in helping us think tactically about how do we take those steps forward. So I'm thrilled she's here to honor my uncle and his legacy, and I know it'll be a treat for all of you as well. Rebecca.
I just have to say that I love so much the notion of a lecture on doing. That makes my heart happy. It is an honor to be here with you today, and I really mean that truly. And especially so because we, all of us in this room, have the great privilege, but equally awesome responsibility of leading at one of the most fraught times in American history and American healthcare. So in my quest to know as best I can who Dr. Levine was, I found a note from one of his patients written after his death, in which he said, "He was the best doctor on the planet, a good man who was blessed with kindness." And I love that so much, not only as a reflection of Dr. Levine, but actually as a mandate for our healthcare system, to be not only excellent, but humane, to not only address disease, but actually to deliver health. And that's what I wanted to speak about today. I think it's important to start at the beginning because it reveals why the work of delivering health, not just healthcare, is both so hard and so important. As a college student, I spent months talking with physicians and nurses at a chaotic hospital in Boston, asking them, what's the one thing your patients most need to be healthy? And they shared the same story again and again, one that we've heard hundreds, honestly, probably thousands of times since, and all of you know, I'm sure, so well. They would say every day we have patients that come into the clinic and the patient has an asthma exacerbation and we prescribe controller medication, but we know that the real issue is that they're living in substandard housing with asbestos and mildew, and we don't ask about those issues because there's nothing we can do. We practice a don't ask, don't tell policy. Now, it seemed it shouldn't be so complicated to design a doctor's visit or our healthcare system around what people actually need to be healthy. So I launched, and then with Rocco Perla, who's here today, led Health Leads, an organization enabling physicians and other healthcare providers across the country to ask their patients, what do you need to be healthy? And then prescribe those things. Fruits and vegetables, heat in the winter, electricity to refrigerate their medication, and we would then navigate patients to those resources in the community. And then one day I got an email that changed my life. And it was from Dr. Jack Geiger, shown here with his colleague Count Gibson. And this is what he said. I thought you might be interested of an historical precedent for Health Leads dating back 45 years when I and other physicians at the nation's first community health center in deeply impoverished rural Bolivar County in the Mississippi Delta literally wrote prescriptions for food. So much milk, so much meat, so much fruit, so much vegetables, etc., for malnourished children and their siblings, to be filled at local grocery stores, which sent the bills to the health center, which paid for them from their pharmacy budget. So it is here that he and his colleague, co-conspirator, Dr. Helen Barnes, picks up the story.
Approximately 3.5 years ago, when I first met Dr. Jack Geiger, he told me about his aspirations of going into Mississippi, into an indigent population, and setting up a community health center, comprehensive community health center. At the time, I thought this was really an idiotic idea since I had already practiced in Mississippi. But in December of 1968, I came to Mississippi and joined Dr. Geiger and his crew of doctors. And after 8.5 months, I can see that these centers are going to be the answer. And the doctors are going to have to get out of their private offices. Medicine may be the way that we got in the door, but medicine is not number one priority. There are other priorities, and those priorities are food, number one. And then the way to make a living, so as to make a man, want to stand up and support his family rather than to go somewhere. Approximately.
It turns out that the other folks who thought that Dr. Geiger's idea was idiotic was the Office of Economic Opportunity in Washington, D.C., which was funding his clinic. And when the OEO leaders found out about these food prescriptions, they sent down a couple of bureaucrats to set Dr. Geiger straight and to tell him that they had intended their dollars to be used for medical care. To which he famously replied, "The last time I checked my textbook, the specific therapy for malnutrition was food." The OEO officials retreated to Washington, D.C. because, as Geiger later recounted, there was nothing they could say to something that stupid and that true. To Dr. Geiger and Barnes, there was something more important than the regulatory structures that ensconce the status quo. It was, as Dr. Barnes explained to me, what my grandmother would call common sense. You get enough people together that have common sense, and you come up with a concept of how you're going to take care of certain things. And once you take care of that, you move on to the next thing, because you always have something else just as bad around the corner. So she explained to me that they didn't just prescribe food. They provided their patients with firewood, window screens, and refrigerators, because that's what their patients needed in Mound Bayou. It just made sense. Now, when Dr. Geiger and Dr. Barnes appeared in my life, I knew I should be proud for HealthLead's place in this multi-generational story. But I was devastated. Decades after they had invented the prescription for basic resources, we had done the same thing, because our healthcare system had gone so fundamentally unchanged in the meantime. Ever since then, one question has consumed me. Why don't we do what we know we need to do to deliver health in this country? Why is change so freaking hard? So over the past 30 years, I've learned 5 lessons about how to affect the change we want to see. And this is what I wish I could go back and tell her, in 1995. Lesson number 1 is don't fall in love with your own stuff. At HealthLeads, we worked our butts off. I mean, we replicated our model to clinics across the country, quintupling the number of families we served till we reached 13,000 patients a year. In 2017, HealthLeads had a board meeting at a health system in Cleveland, Ohio, to mark a milestone, successfully screening all of the pregnant moms at the hospital and navigating them to the resources that they and their babies needed to be healthy. Warm clothes, car seats, healthy food, the works. We spent the day with hospital leadership, the clinic staff, our team, and our board celebrating our work together. But that night, Rocco did some math, as he is wont to do, and figured out we were reaching 0.1% of the patients at that hospital. 0.1%. Even though we had received tons of funding, gotten all sorts of awards, lots of articles written about us, we knew what we were doing, replicating our model clinic by clinic, was just not going to get the job done. There is no way we were going to reach the 85 million plus Americans who needed access to those basic resources. And 6 months later, Rocco and I left to launch the Health Initiative. The truth is, we celebrate people for building things. We do not celebrate them from walking away from what they've built. But we cannot change healthcare or any other system unless we are willing to face and make hard changes ourselves. Lesson number 2, and this is an important one, is it is all about the money. It is really all about the money. In this country, we ask about and argue about healthcare, but how do voters think about health? No one could tell us, so Rocco and I hired one of the leading Republican and leading Democratic polling firms to ask voters across the country, what do you need to be healthy? And we learned a ton. The most important thing is that voters aren't talking about hemoglobin A1C levels or quality-adjusted life years or life expectancy or value-based care. They talk about money, the money that they need to take care of their family. In Charlotte, North Carolina, we asked African-American Democratic women and white Republican women, if you had $100, how would you spend it to buy health for your community? And it turns out they agree, to the very last percentage point, choosing to invest most of their dollars outside of hospitals and about 19% on affordable housing and 25% on healthy food. So I am sure you were thinking, that has got to be a fluke, but it's not. White and Latino male swing voters in Seattle, Washington, white and African-American Democratic women in Cleveland, Ohio, white male Republicans in Dallas, Texas, white low-income Democrats in rural Hendersonville, North Carolina, their answers are strikingly similar. Across race, gender, income, political party, rural, urban, people agree. They asserted that we are accountable for taking care of our health, but we need the building blocks in order to be able to do so, with all the focus groups choosing to spend more money on healthy food and safe housing than on healthcare. We agree on health because, as Dr. Barnes said, it is common sense. It's now widely understood that just 20% of health outcomes are tied to clinical care, whereas up to 70% are tied to these basic drivers of health. But to be clear, that is not how we spend our money as a country. Our healthcare spending dwarfs everything else: education, transportation, food, housing, even defense. We spend $12 billion every day in this country on healthcare, and we are still not buying health. If what we pay for is the ultimate expression of what and who we value, we cannot eliminate disparities, achieve a healthy economy, reduce the cost of housing or food, or do anything else that voters today say they care about unless we unlock these healthcare dollars. But here is the good news. We can change this. We talk about systems, the healthcare system, with this mix of like reverence and despair. But lesson number 3 is that systems are just the piles of choices that people make. And they can make different choices. We can make different choices. In Mandy's first days as Secretary of Health and Human Services in North Carolina, she asked Rocco and me, what if I, as secretary, wanted to buy health, not only health care? How would I do that? It is a simple but powerful question, and it is ultimately accountable to what the American people say, what those pie charts say, which is that we have to spend our healthcare dollars differently. And so it set Mandy, Rocco, and me on a quest. We talked to hundreds of folks, county officials, food and housing leaders, health systems executives, health plan leaders, funders, doctors, nurses, other healthcare providers, and the headline was, our healthcare system is not yet delivering health. So together we homed in on 3 crucial choices that would enable North Carolina at last to buy health. First, measure health, not only healthcare. Second, spend healthcare dollars on health. And third, invest those dollars in communities, not only corporations. Now, there are 1,000 reasons why Mandy could have chosen not to do this. Too complicated, too risky, too likely to annoy or alienate status quo institutions, including her own. Just too much work. And let's be honest, as a first-time secretary in a racially, politically, and geographically divided state, she could have totally gone with the just don't screw it up strategy. But that is not what she did. Instead, under her leadership, North Carolina required all insurance companies providing Medicaid to ask their members, are you struggling with food, housing, transportation, utilities, and interpersonal safety, and report that data to the state, making long invisible suffering visible, quantifiable, and actionable at last. North Carolina secured the Trump administration's approval to use Medicaid dollars to pay for exactly the things the voters said that they needed to be healthy and that research shows improves health outcomes. First month's rent, heat, electricity, healthy food. And instead of paying big out-of-state corporations to provide these resources, North Carolina recognized that its Medicaid dollars could do triple duty, getting people the basics that they needed to be healthy, investing in local economies by paying community organizations to provide those resources, and saving taxpayers money by reducing healthcare costs. Pretty brilliant. Now, it turns out that when we make different choices, we get different outcomes. In the initial evaluation published this spring, North Carolinians who participated in the pilot had fewer ER visits and inpatient admissions, reduced food insecurity and housing instability, cost $85 less per patient per month than those who didn't have access to resources, and to top it all off, the state returned $88 million to communities by paying 147 community organizations to deliver those resources. Every day, leaders in our healthcare system face a choice: to reinforce the status quo, usually while talking about innovation and transformation, or to make different, uncomfortable choices that produce change. So what enables people to make hard choices? Lesson number 4, our own stories give us and others permission to make hard choices, and it is our responsibility to know them and to put them to work. When I was 10, my father lay on the living room floor in the grips of one of his many depressions. As I crouched next to him, he told me that he wanted to kill himself. My father lived but struggled to work, and my family survived, but we teetered, down one salary, relying on my mom's school teacher check. Even as a little kid, I knew we lived in the shadow of financial and emotional collapse. I first said those words out loud 6 years ago, and they are still really hard to say. Because as a kid, I learned you never, ever talk about what's going on at home with other people. It took me decades to be honest with myself that that is why I do this work. Knowing that my father needed healthcare to recover, but to be healthy, my family needed something more. We needed a decent income. And knowing, as so many do more than I, the panic when the basics threaten to slip away. My story is my fuel. It is why I cannot take no for an answer. It's why I won't stop chasing down what the voters say they need, because that's what my family needed and never got. The last lesson is the one that nobody ever talks about. Lesson number 5. To change a system, you must change yourself, and that simply cannot be done alone. I started Health Leads when I was 17 years old, and I spent decades with people asking me, so when is Medicaid and Medicare gonna pay for all of this? And I would say, yes, but I had no idea how to get there. It was like a dot on the horizon. And then Rocco showed up at Health Leads straight from the mothership, the Federal Centers for Medicare and Medicaid Services. We were horrified to learn that he and his colleagues were leading historic health reform and did not know there was food insecurity data in this country. And he was horrified when he told us that we could accelerate Health Leads' work through APMs, alternative payment models, and we looked at him completely blankly. In Rocco, I have a partner who knows the guts of the system intimately, who knows and can predict exactly how and why the bureaucrats and the health plan executives are going to tell us no, and how we might enlist them on our side, who knows the regulatory rabbit holes and can navigate us and our partners through them. Every day, the two of us do the hard work of integrating our dual and often dueling perspectives of healthcare and health, of policymaker and practitioner, of insider and outsider. Negotiating these divides arms us to then do the same out in the world as we translate across health systems leaders and food systems leaders, regulators and corporate executives, those with power and those without power. But it's more than that. Driving change is hard, lonely, often heartbreaking work. Every day you get up and hurl yourself at the impossible, and then you do it again and again. Leading in partnership is about having someone who carries all this with you, who tells you when you screwed up and are thinking about it all wrong, and who also tells you we'll figure it out together, who stays up late to get the work done with you, who reminds you of who you are, and more importantly, who you want to be. Which brings me back to Dr. Geiger and Dr. Barnes. Several years ago, I visited Dr. Barnes in her home in Mississippi, and we talked for hours about her life and her work, but mostly she wanted to talk to me about Jack Geiger and their escapades together, and she wanted to show me this. For Helen Barnes, who came back to Mississippi just for this work, and of course was indispensable. In all our struggles for social justice, you helped make it happen, And against all odds, we survived and grew to this day. And of course, there was the joy of working with you. You will always be one of my dearest comrade in arms. With love, Jack Geiger. No one, not even Dr. Geiger and Dr. Barnes, can change the world alone. So here's the crazy epilogue to this story. On June 17th, 2014, exactly 4 years to the day that I got that email from Dr. Geiger, I received a letter from the Delta Health Center, the one that Dr. Geiger created. And here is what it said. You dared to ask the question Dr. Geiger asked over 50 years ago. What does it take to stay healthy, not only get healthy? Imagine if that question had been answered 50 years ago. Where would our healthcare system be today? Nothing would please Dr. Geiger more than to have you answer that question on the site where the community health centers began, Mound Bayou, Mississippi. So this was extremely stressful. Come explain why the healthcare system has not been transformed. But it was an invitation to the homeland. And so I traveled to Mound Bayou with my then 3-month-old daughter in a blistering Mississippi summer to join Dr. Geiger and his colleagues at the rededication of the Delta Health Center in his name. That night, as we sat at card tables in the clinic waiting room, piled high with fried chicken and collard greens, I listened to their stories, and I finally understood why knowing what to do is not enough. While Geiger and Barnes wrote those prescriptions for food, just the basics of the work entailed unimaginable risk, like securing a fleet of cars marked US government so it was less likely that their community health workers would be car bombed. Sitting next to me at the card table were 2 guests of honor, the very same OEO bureaucrats who had been sent down to unsuccessfully shut down Dr. Geiger's food prescriptions. Seeing my surprise, one of them leaned over and whispered, "You see, it was Dr. Geiger who taught us to break the rules." Today, over 50 years after Dr. Barnes wrote those first prescriptions for cans of carnation milk, and 4 years after Dr. Geiger's passing, I am left wondering, how do we ensure that in another 50 years, this room won't be filled with yet another group of passionate, thoughtful people, just like us, asking, what if 50 years ago, we had figured out how not just to get healthy, but actually to stay healthy? What I have come to realize is that at the end of the day, it's actually not that complicated. It's about what we each choose to do every day and who we do it with that will make all the difference. Thank you. Sure.
Thank you, Rebecca. Fascinating talk and 5 lessons, and I'm glad our public health students are here. And you noticed, where's Rocco? Where is he? Rocco, you have underscored for our students why biostatistics is important, why epidemiology is important. I have an MPH too, guys, so I remember. So let's give Rocco a hand. Making data-driven decisions, right, colleagues? So outstanding, Rocco.
And I just say most of the time, I'm like, I have no idea what you're talking about.
Yeah.
And yet it's what we're supposed to do.
That's right. So first question, then we're going to open up for questions, so please formulate your questions. But I knew Dr. Geiger. I was on the board of an organization here in New York. He was quite infirm in the last few years. So Jack was an amazing guy, and he talked about his work down in Mississippi constantly. You couldn't be in his presence 5 minutes before he started telling you about Mound Bayou and the work he had, amazing work he had done. What a great man. But one of the things I think stuns our students, young students who go into public health, because those of us who go into public health, we're interested in, maternal and child health. We're interested in community health and community health work. And then we get slapped, sort of side the head, as they say down south, with the money issue. And you explicitly said the money makes a difference, right? That one slide that you had that showed the amount of spending that we do in the United States for health and defense, you notice that?
I did notice that, yes.
The best way to describe that, I'm talking to my students, of course. Yeah, we spend most of the money in the United States of America on health and defense. And one of my friends across town here in New York says the best way to describe the federal budget of the United States of America is that we're an insurance company with a military. Think about that. The insurance company is Medicare, Medicaid, and then the defense is the military. And then you saw agriculture was way down there, education way down there. Help our students to, again, understand that when you're in the arena, as Joel liked to say, and as you have been in Rocco and Mandy, the money issue, how do you keep your eye on the money issue, you know, without losing your soul, quote unquote?
Yeah, I mean, I'm so glad that you you talked about that because, you know, it's so funny, like I spent my whole career like literally in the clinic waiting room and, you know, community health centers and academic medical centers. And we would always just sit there being like, why don't they just do this? Like, clearly they should just do this, right? And I think, to be totally honest, it was once Rocco and I started working together that it was like, oh, that's because no one's measuring it and no one's paying for it. And, you know, one of the things that I think was so profound about the North Carolina experiment wasn't actually just the doing, it was the measuring. It was actually saying, like, we cannot begin to wrap our arms around this problem unless we actually have the data. Like, what % of Medicaid members are food insecure? And, you know, Rocco always says, you know, in healthcare, we pay for what we measure, right? Number of surgeries, like number of doses of insulin. And if it is not measured, it won't get paid for. And so I think a huge part of what, you know, the groundwork that Mandy laid in North Carolina was measurement, right? Like that's the same thing you did on vaccines, right? Like you gotta measure this stuff. And one of the huge pieces of work that we've been really focused on is, you know, how do we actually spur CMS and others to actually start to collect that data at a national level. Since, you know, the creation of Medicare and Medicaid in the 1960s, there was never any federal measures in any of the payment models tied to whether patients are running out of food at the end of the month. So of course we don't pay for it, right? And that's been a huge piece of work that Rocco and I and many others have tackled together is how do we get these measures understood to be not community health measures, but actual healthcare measures, so that we can then be in a relationship with how we choose to spend our healthcare dollars.
Yeah, great answer. All right, students, faculty, staff, colleagues, please, questions for Rebecca? Yes, Dawn. I don't think it's on. Click it on. Yeah.
It's on now. Can you all hear me? Yes. Yeah. So we have an election coming up. Healthcare is a primary concern for everyone. How is this information, or is this information getting to the policymakers and decision makers as we listen to candidates talk about what their policies are as it relates to everything but healthcare at this level?
No, I mean, it's such an interesting question. We were actually just talking about this morning, which is that that in some ways, you know, are talking about healthcare policy as a totally different thing from economic policy makes absolutely no sense, right? I mean, this whole talk could just be a talk about economic policy, right? And economic policy is about where is the money and how do we choose to spend our dollars as a country. So, you know, there is, I think, a huge opportunity for us to really be able to say, this is really about how do we steward our resources as a country? How do we choose to spend our next dollar? You know, we talk about reducing the cost of food. We talk about reducing the cost of housing. But to be able to do that, we actually have to look at where the money is, right? And so when you look at that, you're like, of course there's no affordable housing. Like, you can't even find HUD on the bar chart, right? And that's, I think, the real opportunity is that, you know, this may be sort of hard to say, but in some ways it's not because we don't have the money. It's really because we don't have, from a policy-making perspective, a shared framework about how we deploy those resources. I think what's so powerful and what is like the thing that Rocco and I come back to all the time is like the voters are super clear where we should spend the money, right? There is profound alignment. And I think the challenge, to your point, is how do we bridge not just the realities of people's lives, but what they understand they need to be healthy into policy-making reality. When we talk to those voters, I mean, like we spent like, I can't even tell you how many hours talking with folks. They were like, I'll tell you what I need to be healthy. I need healthy food, a safe home, and a good job. And when I get sick, I need to be able to go to the doctor, right? And I think, you know, the engine of our work is how do we drive alignment between this actual profound agreement about what is needed and the policy choices that we make as a country.
Questions, further questions? Yes, please. Don't be bashful, students.
Hi, thank you so much for the talk. My name is Brianna Watson. I'm a second-year doctoral student here. I was invited by Dean Demisi to attend, and I'm so glad I did because this was truly an inspirational talk. But I feel that I also must mention another hat that I wear here at Downstate. I double as the deputy director at the HEAT program, which is a program based around sexual and reproductive health for some of the most vulnerable youth in Brooklyn, and we really work with the queer community, very marginalized folks, and so we are also grant funded, and so much of what I'm hearing about payment models and just so many things really makes me wonder about the sort of stagnant way in which so many state-funded entities really function, and I just wonder, you know, what advice do you have in terms of bringing innovation to those funding entities? You know, how do we bring work like this and the lessons that we're learning here into more rigid institutions?
Oh man, I would love to hand that one off to Rago, having come from the mothership of rigid institutions. I mean, honestly, like, what would you say? Can you hand it to him?
Yeah.
I love that question, and prior to Rebecca and I working, I was actually at the Federal Center for Medicare and Medicaid Innovation, and I think I realized there is that innovation is great. And often sometimes these innovative ideas are so obvious, so clear. We don't need to pilot test them for 10 years. Like, if they don't have a regulatory pathway, if they can't get into the system, the innovation stays outside of it. So how do we think about and research and innovate ways to integrate those ideas into the system? If it's not in the system, it's outside of it. And so I think that's part of the challenge and the opportunity around innovation. Shorten the innovation cycle, the ideas are out there, and then think about getting them into the regulatory mechanisms and the pathways. The whole notion of equity and the economy and value is written in federal rules. There are thousands of them, and that's the opportunity. That's the tactical, practical challenge. I think that's the lens Mandy brought to the work, is like, we've got all these tools. We just need to understand them and integrate these ideas into them because it's what people want.
All right, I get one last question then. Knowing your interactions with Dr. Barnes and Dr. Geiger through your extensive work, what would they opine about the movement in some states to require work as a requirement to participate in Medicaid? Some parts of the country have attempted, particularly under the prior presidential administration, not so much under this one, obviously, that in order for someone to sign up for Medicaid, you have to commit to some sort of work or community service. What would Dr. Barnes and Dr. Geiger say about such policy, prescriptions in terms of access to Medicaid?
I mean, I feel like the last thing I should do is try to channel Dr. Geiger and Dr. Barnes. It feels, anyway. But I will say, I think that they would say that we're just going about it backwards, right? I think they would, I mean, Dr. Barnes says that in the video, right? She's like, we need, it's like, we need to be able to arm folks with the resources they need to be healthy. And when they have the resources to be healthy, they will go to work, right? And it's so like, it's so funny. It's like, I love her thing about her grandmother and common sense, where you're like, but we all know this, so how do we operationalize it? And I think the challenge is, when we talk about, the language we use, right? We talk about Medicaid and other programs as entitlement programs, they're benefit programs, right? Like, they're an economic engine, right? That was the learning in North Carolina, is if you redirect some healthcare dollars to get people the resources they need to be healthy, their health will improve. And it's so interesting because, a huge part of, like, everybody talks about Dr. Geiger's clinic and the community health center, but a huge part of their model was actually putting people to work, right? Like, that was fundamental. They had all this farmland, like, right behind the clinic, and people would come and work the land and bring, literally, like, they were so, that was one of the things he was most proud of, is that it wasn't a clinic in isolation, it was an economy that they were building, right? And the clinic was just the gateway to build an economic engine in this region that would be the ultimate driver of health. And I do think that's what they would call for. The last quick thing I will say about them, and this I feel like I can channel, is Rocco and I had this really awesome conversation with Dr. Geiger at his kitchen table in Brooklyn in the last years of his life. And my favorite part was, of course, when he was starting to lose his eyesight, he asked us to light his cigarette, and I was like, oh God, like, please don't make me do this for you.
Sounds like that.
Anyway, but he said this thing, I remember we asked him this despairing question, how can it be that you've done this for so long and it still hasn't happened? And he got this huge grin on his face, right? And he said, oh, well, you just need to be a joyful warrior. And it was like, it was just amazing. Like, I love that. Like, this is not about the demise, right? Like, this is the chance to do work that we love, that is important, and to fight super hard, but to understand that what sits underneath that is, like, just profound joy. And I think about that all the time when I'm just like, what are we doing? This is impossible. And really try to channel him and that call to rise into the words that he shared that day with us. So anyway, thank you.
That is wonderful. Well, Rebecca, one more question? Yeah, there's another question? Yeah, please.
Hello, thank you so much for your talk. My name is Gulshan Ashok. I'm an MS1 student here at SUNY Downstate. I had a question. So you had mentioned a beautiful line where you said, it's about the choices we make in our daily lives and the people you make those choices with. And that really made me think about preventative medicine and how can we better incorporate preventative medicine when it comes to investing in health in ways that are effective, but also reducing costs when we approach that.
Yeah, this is like, oh my God, the huge riddle, right, of how do we do this? And I think, I really do think that, North Carolina was like a super strategic version of how to do that, right? And I do think that the pathway is tricky in that, we know that's the right answer, but that we actually have to build our way into operationalizing that, right? And so the work in North Carolina was to say, hey, listen, like, if you're going to the ER a bunch, like, we're gonna then pay for you to get the resources that you need to be healthy. And I think this is a little bit of that tension between just, like, honestly knowing what the right answer is and wanting to skip ahead, and then really beginning to lay the foundation to be able to do that. And I think North Carolina is just, like, such a perfect example of saying, like, how do we start at the beginning and understand that we can build this case over time, but we have to be methodical in how to do that, right? It's what Rocco said. Mandy was like, I remember so distinctly, like, I have all these tools at my disposal. How do I use them to maximize health? Like, every day, every person, every choice, can we keep crowding in towards health? And I think that's the opportunity, is to keep looking for those choices and tilting them towards health.
Thank you so much.
Another question, great.
Wait, Mandy wants to answer.
Mandy. Yes, please.
Maybe to just, since prevention is in the title of my job. Right.
It is disease control and
Right.
prevention. Yes.
But I want to say to the public health students, a lot of what we are doing at CDC right now as we learn lessons from the pandemic is that public health cannot be siloed from the health delivery system, and too often it isn't. And if you want to change health overall for communities, that you actually have to know what is measured and what is paid for, bottom line. So, and what we are doing at CDC is a fundamental education about how the Centers for Medicare and Medicaid work. And luckily, I was the chief operating officer at CMS before I went to North Carolina and before I came back to CDC, and that was very intentional, right? Because again, what you pay for matters to how the system performs. So CDC is great. We have these great data about how we want to, for example, get more people vaccinated. But guess where people get vaccinated? In pharmacies, in doctors' offices, right? Not in public health departments often. And so what we've been doing is thinking about how do we measure it, what are we paying for, and then how do you think about the operations of how pharmacies, clinics, and other places work. So I spent last week at Epic. I don't know if y'all use Epic, if you're Epic, right? So the care gap closure list, right? I don't know if you're care gap closure folks, but I need CDC to think about the care gap closure list on Epic if we want to get more people vaccinated. It's getting into that kind of granular detail, right? Because if you don't measure it, right, those care gaps, and then if you don't have insurance coverage to pay for it, we're not going to make changes here. And so too often, I think public health sits too far outside the delivery system and isn't thinking about measurement, payment, and operations. And that is how I move through the world, as you can see in my, and so I would just encourage you to really understand how things are measured, how things are paid for, how things are operationalized in order to make change here. And like that is those are the linkage points that we're trying to make, I think, in order to change and to do something different. Okay.
Dean Lewis, you get the last word. Yeah?
Thank you very much, and great talk, Rebecca. And I'm Dean Lewis, School of Health Professions, and I'm an academic now, but formerly I was a doer. I worked for 15 years in state government. I was actually director of a state cancer registry for a number of years, so I know a little bit about public health. I do know there's a model. This is mostly this comment and question for our students. There is a model in public health called the social ecological model out of UNC, 1988. McLeroy, Glantz, Beckler, and Bibbo, I do believe. And so the overarching theme that I'm taking away from this, which is not unlike many themes of these talks, is that change is the thing we need to be better at, obviously. So that model says that, and it's out of health promotion, I believe, that in order for change to be successful, there have to be systematic strategies that are aligned across 5 levels: individuals, interpersonal relationships, individuals in their immediate context, organizations, communities, and obviously policy. So my question to the students and anybody else at Onie is, how do we bring up the alignment that we need across those 5 strategies to bring about the level of change needed to address this kind of challenge? You know, we have a lot of models, we have a lot of tools, but we don't always actualize them to actually make things happen. So how do we use those models, particularly that one, to bring about the change?
I mean, I really love what you just said, because I think in some ways my own journey in this question of like, how do we affect change totally follows that, right? I mean, the first question I want to understand is like, how do we get people the things they need, like actual humans, like individuals, right? And I mean, just like filling out a SNAP application, right, a food stamps application is super hard and tricky, right? And I think to your point, the question is, I think a lot of our models and programs and interventions never take flight from that. And so we are just like slogging it out person by person, clinic by clinic. And I think the model that you described is so important because it actually compels us to say, like, the way we honor the work of getting individual people what they need is to actually think about all those levels of impact, right? And, I think it's so funny because it's like the SNAP application is impossible to complete because the policy that sat at the top trickles down and makes it impossible to complete. Like, that's not an accident, that was a choice, right? And so just like, how do we, as we go into the world, just relentlessly ask ourselves whether the work we are doing is valid at all the levels that you described?
Well, another question. Yes, Rebecca, you've stimulated us. Yes, please. I love it.
I feel like we should get like a panel up here. Like, I'm like, why do I have to answer all these questions?
Hello, everyone. I'm Zakia, and I'm a second-year MPH student. And I agree, and I think a lot of it is also outside of like clinic and hospital settings, which is where I think public health does like interact or like mediate between like direct health care, because a lot of the things that people need are not necessarily accessible to them because a lot of people don't go to the doctor. A lot of people don't trust doctors. A lot of people don't have ways to get to these clinics. So I think like interacting more on the community settings, like within the churches and the cafes and the libraries, would be a good way to segue. And the question I was going to ask was, as you worked within the different hospitals and you were able to reach that 0.1%, how would you then navigate helping the people that never go to the hospital get access to the things that they need? Because there are many women that give birth at home or in like different facilities and stuff like that. So knowing that they still need access to better nutrition and car seats and formula, what ways could we help those people that are not in clinic settings?
Yeah, I mean, this is such a important and age-old question of this work, right? Is like, what is the gateway that we use? And, it's interesting because Health Lead's model, which was, okay, how to use the clinic as a gateway to connect patients with the basic resources they need, is mirrored almost entirely by another model called Communities and Schools that uses schools as a gateway to connect people with the resources they need. And I think, this is the, we have all these, phrases for this, like the all government approach or the braided fund. There's like all this stuff, right? But the bottom line is we have all of these assets, right? We have the assets of the healthcare system. We have the assets of the education system. Like, we have the assets of all the community institutions that you were just talking about, right? Like, literally, in Chicago, where I spent a bunch of time, there was, I'm sure you guys have studied this and have learned about this, but like using barbershops as a gateway to be able to do health education. I think the challenge is like, we just don't do it systematically, right? It's like, it's programs here, it's episodic, it's not systematic, it's not like, okay, we're trying to achieve this objective. What is every institutional asset we can use? And I think that's where, like, when I think about aspirations for like the next wave of leadership, is to be able to take all this stuff and, and to organize it, right? That's like, I love your like third thing of like, measuring, paying, and then organizing stuff, right? And I think it's perceived as just the not glamorous work. It's not, you don't like do your PhD in organizing stuff, but like when you're on the ground, like that is what is actually needed to get the job done. And how do we just get more honest about what's required to move the needle for people? Stop, pretending that it's like, it's either all policy making or it's all programs. Like, in between those things is where people live their lives. And there's just like I would love for that to be life's work for so many people.
Great answer. Well, students, ladies and gentlemen, colleagues, what a great presentation by Rebecca Onie. Let's give her a round of applause. Our tremendous students here at Downstate, thank you for coming here, and I love your questions, your curiosity to hear from someone who's in the arena, and to hear lessons learned. Part of the way we try to prepare you for the work ahead is bring you people like Dr. Cohen and Rebecca Onie, who are in the arena, who have had to negotiate and fight for resources and be very skillful in how they design programs. And so you have two great examples here. And again, in honor of the great man we honor by having Rebecca with us, Dr. Levine, Joel would love this whole discussion. And he particularly would have loved the questions from our students. So lessons learned, we want to salute the happy warrior, Rebecca Onie. She is a happy warrior. So let's give her a round of applause. Thank you for coming.